Hi everyone, my name is Adrienne Young and I'm the Research Coordinator of the Nutrition and Dietetics Department at the Royal Brisbane and Women's Hospital. And following on from Sonia's presentation around the implementation process and frameworks that we might use, I'd like to spend the next half an hour talking you through a case example, which I hope will demonstrate why it's really important to take a structured and systematic approach to implementation and how frameworks can help to guide you through this process. I must say up front that this is slightly embarrassing to present this project because it really isn't a good example of successful implementation, and I think that there's some real value in presenting a case that doesn't go well because it's easy to identify what went wrong and what we could do better. And I've certainly learned a lot since this time. This was almost 10 years ago now, but also even just the process of reflecting back on the process and the outcomes has been really useful. So I'll talk you through the case example, and then I'll step you through the i-PARIHS framework, and we can work together to look at what I did, what I should have done, and what I should have considered when I was planning the implementation. So this case is set on an orthopaedic ward, and the NUM and the dietitian of the ward decided that their ward really should be providing better mealtime care. So there was a high number of patients at nutrition risk, lots of frail elderly patients as you'd expect, patients who needed help with their meal after fracturing their arm or needing a neck brace on, and we knew from hospital-wide audits that malnutrition affected around 25% of our inpatients. So the NUM and the dietitian got together with the ward physio and a nurse that was nominated by the NUM to come along, and there was a discussion around what the mealtime issues were, lots of venting, lots of identifying issues, and there were two main things that came up. The first was that the surgeons always come around at breakfast and interrupt patients while they're eating their meal, and the second was that patients weren't provided with enough feeding assistance. So these were the main two issues that were identified. So when we look at the evidence, we know that there's strong evidence that malnutrition is common and a significant problem in hospitals. There's really no question about that. And we know from local audits that this is the case at Royal Brisbane and Women's Hospital. Strategies such as red trays and protected meal times implemented throughout the UK and are well-known strategies to address poor intake and hospital malnutrition. And there was some local evidence from the medical wards at Royal Brisbane that these strategies may improve mealtime care and nutritional intake as part of the EAT study. And this was really what led the orthopaedic NUM and the dietitian to wanting to improve their mealtime care, was seeing the success of these programs on the medical wards. So over the next month, the dietitian and the NUM used three main strategies to implement better mealtime care. The first was that we introduced red trays. So patients who needed feeding assistance were identified and their meal was delivered on a coloured tray, which would then flag to everybody that this was a person who needed some extra help. So the dietitian developed written protocols to help guide the staff through how to identify somebody as needing a tray, how to order one for staff in the kitchen, then where do they put the red trays and what does that mean, and then who then is responsible for providing the mealtime assistance. So there was a lot of consultation throughout that process. Then the next strategy was increasing awareness around when the meal times were, so that all staff knew not to interrupt people and to encourage them to provide assistance during this time. And the third strategy was education. So there were 3 in-services which talked the nurses through why nutrition's a problem, why we need to be providing better mealtime care, and talk them through the processes around the red trays. So after the red trays were introduced, the dietitian noticed on her regular mealtime rounds that not all patients who needed feeding assistance were getting a red tray. And patients with the red trays didn't really seem to be getting any extra help compared with those who had the regular trays. So the dietitian talked to the NUM about this. He said she'd keep reminding her staff and keep on top of them. And not long after the implementation, the dietitian rotated workloads and handed the project over to the new dietitian. That happens all too frequently, and it can really prevent a project from going forward, especially in these early days. And in fact, nothing really much happened with all of this from then. So if we take the i-PARIHS framework, we can begin to understand what we did and what we should have done in this example. So talking you briefly through the i-PARIHS framework again, it names facilitation as the active element required for successful implementation. So the facilitator sits here right at the centre, and this is the person who brings together the people or recipients. So in this case, this is the ward staff on the orthopaedic ward, to implement the necessary changes to practice. So this is our innovation, so in this case the red trays, to introduce this innovation within the context in which they're working. So in this case the ward, and also the broader hospital context, and then for some interventions also we're thinking about the external context of what's going on outside of the hospital and the political environment in society more broadly. So if we start with our facilitator, in this case this was the ward dietitian, and on reflection this dietitian had a lot of the skills required by a good facilitator. She was very organised, she was very enthusiastic, she had good project management skills, she could bring people together to work through solutions to the problem. She demonstrated that by bringing together a working group, by developing up this written protocol. And I think it's true for many dietitians. I think we're natural facilitators. It's what we do on a daily basis with our patients and our clients. However, I think what was missing with the facilitator was them having a structured approach to assessing and matching this innovation to the recipients and the context that meant that the implementation wasn't a success. So I'll talk you through each of these different elements, starting with the innovation, around what we did and what we should have considered and what we could have done. So in this case, the innovation was, there were two. There were the red trays and the posters aimed at increasing feeding assistance and reducing the mealtime interruptions by the doctors. But these solutions were based on assumptions about what the problem was and what was causing them, rather than gaining an understanding of the problem better and how this might be addressed. So basically we went in with a solution before understanding the problem. So what we should have considered was what evidence there was, what are the knowledge sources, how clear is our intervention, how does it fit with existing practice and ward values, how usable it is, how much better is it than normal practice, is it something that we could trial on a small basis, and what were the results that would be able to be seen. So I'd like you to pause the webinar for a couple of minutes and have a think about maybe what we should or could have done better when selecting and developing the innovation. So have a think back to the earlier presentations in the series by Barbara and Shelley about identifying the clinical problem and looking at the evidence, and having a think about what we could have done better when we selected the red trays and posters as our innovation. Okay, so the first thing we should have done was to look at the evidence. We should have looked both at the local evidence, so current practice, and this would have helped us to understand if there actually was a problem with mealtime assistance and interruptions and exactly what that problem was. So we actually had no idea what was happening in practice. We should have gained some feedback from staff to help us to know what their experience is, and do interruptions actually affect their intake, and to have some objective data around the proportion of patients who were getting the help that they needed, how many people were getting interrupted, who was interrupting and what for. And then that would really have helped us to target this intervention. We may still have used red trays, but there might have been some other strategies. So without exploring this properly, there's a risk that the strategy that we put in place doesn't actually address the true problem. And we really needed that baseline data to allow us to evaluate the impact of the innovation on care and patient outcomes. So in this case, we didn't collect any baseline data, so we weren't able to conduct any meaningful evaluation. We definitely should have looked at the research evidence for the proposed innovation. And at the time, and even now, there really is no evidence that using food trays improves mealtime that using red trays improves mealtime assistance or food intake. And similarly, the evidence for protected mealtimes was not strong. And there may have been other evidence-based strategies that we should have considered. So getting a really good feel for what we know works, what maybe might work, and what doesn't work to inform what innovation we select. And we also need to look at the characteristics of the innovation itself and how it is matched to the recipients and context. So is it likely to be accepted by the recipient, so the patient's family and staff? This was identified as a potential problem after the fact, so the nurses didn't feel that they needed red trays to tell them which of their patients needed help. We also didn't consider what impact, if any, that this would have on patients. So would they be grateful that their needs were being identified and flagged to the ward, or would they maybe resent being singled out and identified as being dependent, or would they even notice? And we didn't explore any of that. Does the innovation require significant changes to current processes or ways of thinking? So in this case, nurses weren't routinely assessing and documenting whether patients needed feeding assistance. So this was a huge hurdle in identifying patients who needed help. So we probably should have worked on that end of it first, so that we had systems in places for identifying patients who needed help and then adding in the red trays down the track. And we know that interventions are easier to implement if they're clear, usable, trialable, and allow us to see observable results. And I think in this case, clarity can be an issue. So who was going to order the red trays, and who was then to action the feeding assistance? And even though we had a protocol around that, there was still a lot of confusion about who was actually responsible for that. Was it our dietetic assistants? Was it the nurses? Was it the dietitian? Who's responsible for feeding? Is it the food service officers? Is it the nurses? Is it the dietetic assistants? And how do these groups work together? And we should have spent some more time on that. And the same with the posters. They were just stuck up on the ward. Who were they for? Were they for the patients? Were they for the carers? Was it for the staff? Would an orthopaedic surgeon ever look at a poster? So putting some thought behind these, that as an innovation certainly would have been useful. If we move then on to the recipients, in this case there were real positives in terms of the recipients. So we knew that we had a motivated NUM and dietitian who had identified a problem and wanted to fix it. They wanted to work together to do this. There was a shared vision amongst the multidisciplinary working group that was convened, and there was a designated nurse champion. However, the nurses were really the only recipients considered when implementing the intervention, and little was done to really assess whether they wanted to change mealtime practices and whether they had the capability to change. And so we really should have spent some time understanding their motivation, their values and beliefs, goals, whether they had the skills, knowledge, time, resources, support, how the nurses worked together, so how they influenced each other, who were the opinion leaders, how does the team work, how do they see their roles and who does what on the ward, and how do the recipients work together to provide care. So again, I'll ask you to pause the webinar and take a few minutes to think about whether there are any other key recipients that might have been important, and brainstorm a few specific things that we should have or could have done to better assess the motivation and capability of the recipients, or the nurses and any others, to change mealtime practices. So as you can see, we should have spent a lot more time understanding our recipients, what motivates them and what they needed to be able to make the change required. This takes time, so you need to spend lots of time within the context and having many conversations to understand who needs to be involved. And these conversations can often be uncomfortable. You're challenging and really asking people what their values are. What do you see as your role, and who does this, and why don't you do this? And they're difficult conversations to have, and they take time to develop trust and to understand how things work. And there needs to be conversations with many different people. So there are formal leaders, there are informal champions, there might be some tricky individuals who have the potential to negatively influence others. So really identifying who has sway in the context, what motivates them, and how to get them on side or how to manage them. We need to understand how the recipients interact and influence each other, and what their priorities are, and any knowledge and skills gaps. So on reflection, nutrition was on the agenda for the NUM and the dietitian, but it wasn't included in any sort of shared vision or ward vision. There really wasn't one. Mealtime care was seen by nurses to be a burden, wasn't a valued task. There was a strong emphasis on the ward on technical aspects of nursing care rather than fundamentals of care. And there were some nurses who had really strong opinions about nutrition. These were the opinion leaders on the wards, and they felt they were doing a really good job and that they didn't need to change a thing. And if anyone tells me that I need to change a thing, I'm going to challenge that. So that is a difficult place to start, and so we really should have spent a lot more time understanding that and how we could work with people where they were. The first point there is, who are the recipients? So we didn't consider anybody else, but we probably should have attempted to engage the surgeons at least. The orthogeriatric unit might have been a good ally. There was an enthusiastic OT on the ward, so getting him involved. Maybe the AINs and the dietetic assistants as well as part of that group. So if we move then into the inner context, in this case, that was the orthopaedic ward, and we knew that we had formal leadership from the NUM. So she was the formal leader of the ward, and that's critical to success. However, we didn't see any change in staff behaviours despite having the NUM really on board and really wanting to do this. So we probably should have found out a bit more about the leadership style of the NUM. Are they able to motivate their staff and create a vision for the ward that includes nutrition? Perhaps there were other formal or informal leaders that we needed to engage. As I mentioned before, maybe the orthogeriatric consultant, maybe another senior nurse or a senior allied health professional who had considerable influence over how things were done on the board. Maybe getting that nurse who says, I think we're doing a great job, and don't tell me otherwise. Getting them on board and trying to influence them might have been useful. Might have been difficult, but might have been useful. And on reflection, this ward had a culture that did not embrace change and did not value nutrition at all. They were a group of nurses that were really quite disempowered. They felt like they had no ability to change. They hadn't had good experience in the past with change. Change was often imposed on them. And so this was a difficult environment to implement something new. And in fact, there hasn't been a lot of change on this ward in the past 8 years, despite significant efforts by very experienced implementers. And so it makes me think that maybe this innovation may have actually never worked. But we might have had a better shot of it if we had have thought through the process a bit more. So getting to know the inner context takes significant time. It's helpful if you have someone who's an insider to assist in providing the history and details of what happens on the ward, who does what, why things are the way they are. So teaming up with one of the senior nurses, one of the allied health professionals, if you've got a NUM who's a really strong leader and able to influence change, getting a number of insiders involved. But also having an outsider can be really invaluable. So having somebody there that can step up and ask the difficult questions that might be difficult for somebody embedded in the ward, may not be able to do. Having someone external to offer an objective assessment of what is happening and what barriers are present, because sometimes you can't really see that when you're in there, and they can then help recipients to see an alternative point of view or an alternative way of doing things. So I'd strongly recommend that you have a bit of a team. We sometimes call it a good guy, bad guy kind of team, where you've got that insider who can gain the trust, understand what's happening, really get in there and get a good detailed understanding of why things are the way they are, and who needs to be involved. But then having this outsider, this bad guy there, to be the one that can challenge everybody to see a different point of view. In this case example, we didn't consider anything outside of the ward itself. We didn't know anything about how the external organisation may have impacted on things. But this is really important to consider and becomes more and more important as the scale of your project increases. So if you are doing a very small, focused, quite simple intervention, then you may not need to think about the organisational or the outer context. But as you start to scale up, if you're wanting to do things, say, across all of the medical wards in your hospital, or across all of the wards in your hospital, or even rolling out then to other sites, then really thinking about how the organisational context and that outer context may help or hinder your progress. So for a ward-based project like this, we really should have had a basic understanding of how the organisation works, what the strategic priorities are, and how our project aligned with those. So maybe looking at how the incident of pressure injuries and falls, consumer feedback and engagement was really high on the organisation's agenda. So how could we align this project with that to kick some goals around some of that? Bringing in the accreditation standards can be really useful, because nurse managers need to be reporting on what they're doing to meet accreditation standards. So if you can go and say that your project will help them to do that, and you'll help them to build a case to how they're meeting or exceeding the standards, then that is always very well accepted. We should have understood who were the key people that we needed to have on our team to support our project from outside. So these might have been different nutrition committees or directors of allied health or surgery or nursing, so somebody else to be there and influencing the nurse leaders and the other staff. Thinking about whether there's a culture that supports innovation and change, or whether the organisation tends to stay with the status quo. So if you're going in there and suggesting big changes when this is an organisation that just plods along and doesn't ever really change things, and we do things because that's the way we've always done it, that's going to be a lot harder to change than a progressive organisation that embraces change and is constantly striving to improve practice. So it can be hard for clinicians to have a good feel for these things, and so it can be really important to have a project sponsor or an informant or an advocate at the service line or executive level to provide this kind of context and to see how your project might fit with other things that are going on. I've listed at the bottom there some of the outer context things. So I talked about accreditation, and we really should have thought about that there. But then thinking about any accreditations, any policy drivers or the priorities in the broader health system, stability in the environment, in the political environment, and what impact that might have, and any networks with other organisations and relationships that could help with your project. So the outcomes of this project, I don't have any to share because there was no evaluation planned at all. See what? And as a researcher, this is embarrassing to admit. We didn't collect any baseline data, so we weren't able to evaluate, and we really should have thought carefully about what outcomes would we expect to change, how are we going to measure them, how are we going to know if we've been successful in what we've set out to do. And the final session in these webinars focuses on evaluation. So it might be useful for you to be thinking about this case example when they're talking about evaluation, and thinking about, well, what should we have done, and how should we have done that? And just to finish up, some final remarks about what we learnt and what we would never do again, so the light and the dark. So from reflecting back on this example, it's certainly confirmed with me that using implementation frameworks provides a systematic way of assessing the innovation, context and recipient, and this is invaluable. On reflection, I'm glad that we piloted this project in just one ward rather than aiming to do a big hospital-wide project, because that would certainly have failed. And when we're looking at a hospital-wide project, we really need to be thinking much more about the context and the organisational context, and having that support higher up is really important. And I think when we're embarking on something like that, we really need to be using a structured implementation framework to help us to do that. What would we never do again? So implement without a framework, and being familiar with these frameworks now, it almost becomes second nature to be thinking about some of this. I would never implement without evaluation again, and I think that's certainly something that we're getting much better at. And what I'd never do again is try to replicate what has worked somewhere else without tailoring to the context and the recipient. So really this project was about taking a program that was developed for one context and implemented, and the results were seen in that context, and then it was really just tried to take that idea and put it somewhere else, and that doesn't work. Different wards have very different ways of operating. You'll know from working from ward to ward that the way that the teams work is different, the way that the NUM works is different, where their priorities, the way they approach care is different. And so it makes sense that you can't just take a protocol from one ward and put it in place in another, and that's certainly something that I would not be doing again. So I hope that by exposing myself here and presenting this example of implementation gone wrong, that this has given you a little bit of an idea of how a framework might help to think through the process, and as might help you in going forth with your own implementation project. Thank you.